Hello, good morning to Dr. Mike Nayak and Dr. Steve Cohen, and a very good evening to most of the participants from Thailand. We have from India, I think in this part of the world, and it's actually a late night over here in Melbourne. Thank you very much for taking your time to participate in our second webinar by face by face. And today we have our speaker, Dr. Mike Nayak, to give his presentation. And Dr. Kabo Watanakrai will be the moderator. So my name is Eddie. Before that, maybe let me kindly introduce a very good friend, Dr. Kamo Watanakrai from Thailand. He is a board certified plastic surgeon since 1985 and founder of Bangkok Skin Plastic Surgery Center. He has served as chairman of the Department of Surgery at Bhumipol Aduwajet Hospital 2005 to 2009, president of both the Oriental Society of Aesthetic Plastic Surgery and Society of Aesthetic Plastic Surgery of Thailand, and National Secretary of ISEPS. He is currently sits on the board of directors of the Rhinoplasty Science Society of Asia and advisory boards of Thai plastic surgery societies. Widely published in aesthetic surgery, his work includes innovation in eyelid and facial regeneration techniques. Dr. Kamo has earned multiple honors, including 2024 PRS Best Paper Award for his eyelid fold correction algorithm. So with that, I would pass on the introduction to Dr. Kamo, where he will introduce Dr. Mark Nayak. Dr. Kamo.
Good evening. I'm pleased to moderate this interesting topic of the preservation deep plane facelift by Dr. Mike Nayak, who is a famous facial plastic surgeon from St. Louis, USA. He had been honored one of the America-based plastic surgeon in this year by the Newsweek magazine. So before we dive into Dr. Nayak's advanced lecture, may I give a quick look of deep plane facelift for our audience who might not familiar with this technique. May I have my slide, just one slide, please. So deep plane facelift is so popular nowadays. You can see the topic of this deep plane in almost all plastic surgery meeting, and that dealing with the face. So even in the social media advertisement, this overwhelmed with many surgeons showing their expertise in the deep plane facelift. So I am going to review to our novice surgeon that deep plane facelift is not new, but it has gone through several evolutions in the last 20 years by our pioneer plastic surgeon. You can trace back to 1974 when Scoop introduced the skin smash flap at a single layer, but he didn't mention about the ligament release. So Hamla has introduced the composite flap, include the ocular muscle, that is a deep plane facelift. So nowadays there are many prominent surgeons doing the deep plane facelift. It looked like the gold standard for our facelift nowadays. So the classic deep plane facelift, like Mendelssohn and many of us also doing this, it composed of the ligament release. You have the composite flap of the smash and skin, not a separate flap. And there are a classic entering point from the lateral canthus to the angle of the elbow, the green line in the picture here. So nowadays there are variation of deep plane to entering by the entering different part of the smash. So something like the high smash also. And the most interesting one nowadays is the preservation of the deep plane facelift. So we are lucky to learn this innovative technique from the one who is the pioneer in this field. May I have Dr. Mike Nayak, please.
Thank you for the introduction. I appreciate it. And that was actually a perfect introduction to what I'll be presenting. That couldn't have been better. Let me know when I should share my screen here. Should I share my screen to be able to do the presentation?
Yes, you can share your presentation, Dr. Mike.
Okay, perfect. Okay, can everybody see my presentation okay?
Yes.
Okay.
Yes.
So my goal today is to give you an introduction to this topic. An exhaustive covering we'll do at the IFATS meeting, but this will be at least an introduction to the topic to hopefully get you very excited about it and let you get a feeling for why I'm so excited about it. So the woman you're seeing here, this is her pre-state. She's 64, and that's the day after her surgery. And I will be showing you later in the presentation her 6-month and 1 year results. But I will just say, before I was doing this preservation approach, I was beating my patients up way more for a much less refined, much less beautiful result. And it's one of the rare things in my practice where I can truly say it's half the work and twice the result of what I used to be getting. And I get it safer, easier, and better. And it's rare that you get all that at once. So that's why I'm so excited about this procedure. So I have a disclosure. I do make videos for QMP. I make a tiny royalty on them, but technically that's a financial disclosure. Actually, now there are 3 volumes of the Facelift series, so more of those out there. So this is a young middle-aged woman who came to my practice 5 years ago for lower blepharoplasty. And I normally do my lower blepharoplasty with transconjunctival fat removal and then free fat grafting to the tear trough, malar cheek, etc. But she was so lean that really was not a good person to try to do any free fat transfer on because she had no body fat. So I did a fat transposition lower blepharoplasty on her. And she came back 5 years later. So this is 5 years after her fat transposition lower blepharoplasty, and the lid cheek junction is better. But now she's back for face neck lifting. And she has, again, no subcutaneous fat at all. And what makes her interesting is you can see, my pointer isn't working here, but you can see her platysma, you can see it immediately through the surface of the skin. And you can see how thin it is. It's a completely just ephemeral layer of tissue. And then you can see the sagging of the SMAS all the way forward into her jowl. So vertical sagging quite anteriorly, almost near the oral commissure. And then you can see the fullness of her submandibular gland in the neck. And again, this is the kind of result that I could not have achieved prior to this preservation lift. The main reason, so one, we sculpt the neck, and at IFATS I'll be giving a presentation about deep neck sculpture as well. But the neck contour was achieved by sculpture, and without sculpture, there's no amount of lifting the investing tissues that would have gotten that to look right. Once we sculpt the neck, then it's a matter of lifting the investing tissues, which is skin, subcutaneous fat, SMAS platysma unit. And doing it in this preservation manner allows me to get this kind of result, even though her SMAS platysma unit is terrible, because we're keeping the SMAS platysma unit almost entirely attached to the overlying skin. And the overlying skin serves as a reinforcing to the SMAS platysma unit. So it's interesting. By minimizing delamination, which I'll show you in a minute, it prevents injury of the subcutaneous fat and skin, but it also promotes strength of the SMAS platysma, which is the layer that you're doing your lift on. So by keeping those two as composite as possible, it improves the performance of both of those layers. It improves the strength of the SMAS platysma unit, and it decreases the injury of the skin unit. So neck rejuvenation is largely deep subtraction. We don't get neck rejuvenation by lifting the SMAS platysma. We get it by sculpting the foundation. Once, and again, in IFATs, we'll go over detail about what I do for deep subtraction, what I do for sculpture of the neck. Today, we're going to touch a little bit on the preservation lift, which is once we've got the neck sculpted, now we're going to lift the skin SMAS platysma fibromuscular unit into that new shape. And as Dr. Kamal just said, perfect lead into this presentation. All of these deep plane lifts, they share a history. They share a commonality in that all of these lifts are being performed in layer 4 of the face. So layer 1 subcutaneous is skin, 2 subcutaneous tissue, 3 is the SMAS platysma unit, 4 is the potential space deep to the platysma, deep to orbicularis oculi, deep to temporoparietal fascia. And the way the face ages is we all look at the face and we say, oh, they have so much loose skin. Well, the skin is bound tightly to the SMAS platysma unit. And then there's a glide plane in layer 4 between the SMAS platysma unit and the parotid masseteric fascia, the deep temporal fascia, the deep cervical fascia. And that can slide. And that whole layer slides as a unit. It swings forward. It all slides and swings forward as a unit. And that is the layer that aging happens in. The skin is not sliding freely on top of platysma, orbicularis, temporoparietal fascia. It's bound tightly to those. It's those layers that are sliding in layer 4 atop of the deeper structures. So if we're trying to create natural youth, we need to position what actually fell back where it started. Our lift needs to occur within layer 4, and we shouldn't be separating layer 1 from layer 2 as we destroy layer 1 from layer 3 as we destroy layer 2. We should leave 1, 2, and 3 intact as much as possible. As Dr. Kamal said, the classic B-plane entry, lateral canthus or lateral orbital rim to the angle of mandible. That's the red line that I have drawn. The yellow line that I have drawn is Pitanguy's line, approximate prediction of the temporal branch of the facial nerve. Where I'm entering my deep plane now approximates a high SMAS entry point, which is the blue line. And obviously the blue line overlaps the yellow line. But if you raise this correctly and you raise the fixed SMAS just under the plane of the fixed SMAS, the temporal branch is really deep over the zygoma. And you can absolutely, as many high SMAS surgeons do routinely, you can absolutely raise the SMAS off even that far posteriorly and be safe. Why am I raising it so far posteriorly? I will tell you there's lots of advantages. So first, if you're just getting into deep plane facelifting or preservation deep plane facelifting, the safest place to enter the sub-SMAS plane is low over the border, over the angle of the mandible. Because when you enter over the angle of the mandible, you are entering directly over the parotid gland, the main part of the parotid gland. So the red line is the SMAS incision. The blue line is the anterior aspect of the parotid. And then the green lines are facial nerve branches leaving from the anterior aspect of the parotid. So for people that are just getting started in deep plane facelifting, and for everyone, the safest place to find layer 4 is the lower half of the face because the plane is just much more evident. And if you get a little bit deep, you have the body, the parotid protecting you. Once we, and so again, layer 4 subplatysmal is easy to find. I incorporate the lower part of orbicularis oculi into my facelift flap. So technically I'm doing a composite style deep plane facelift. It's composite in 2 ways. It's composite in the HAMRA use of the word, meaning the orbicularis is incorporated in the flap. And it's composite in the plastic surgery, bigger sense of the word, meaning we have multiple tissue types within our flap. So I find it very easy to find the deep plane under the platysma. I find it very easy to find the deep plane by defining the prezygomatic space under the orbicularis. And then we can continue that plane across the middle section of the face. As far as keeping facial nerve branches safe, again, when we enter over the angle of the mandible, we're behind where the facial nerve branches exit the parotid. So it's a really safe place. You find an easy pre-masseteric space and continue. Over the zygoma, if you enter at least within the first 19 millimeters lateral to the orbital rim, you're already anterior to the temporal branch of the facial nerve. So even if you get too deep, you're safe. The temporal branch is going to exist at least 19 millimeters behind the lateral orbital rim. So if you're a beginning surgeon and you want to be especially safe, maybe don't retroplace the superior aspect of the deep plane entry flap more than 19 millimeters from the lateral orbital rim. And at that point, it doesn't matter how deep you get, you're not going to injure the temporal branch. When we're connecting between the easy places under the orbicularis and under the platysma, when we're trying to continue that dissection across the midsection of the face, how your assistant holds the retractors can make your life a lot easier. So if the assistant is holding the retractors straight vertically, the middle section of the face, the fibrous sheet, isn't under good tension, and it kind of bows, and you're trying to follow a plane that isn't under tension and is curved. I call it bunny ears. If you have the assistant retracting in bunny ears fashion, it straightens and tenses the fibroseptal sheet, the SMAS, in the midsection of the face, in the buccal face, and it makes it much easier to follow and much safer to follow that plane. So your assistant retracting the appropriate fashion can make your life easier when you're connecting the two easy spaces across the little more tricky space. When we do this deep plane dissection, I've been doing deep plane facelifts of one fashion or another for about 22 years. And when I first started doing deep plane facelifts, the definition was we entered the deep plane, but we were not carrying the dissection forward into the face nearly as far as we have in the last 8-10 years. And so, the word deep plane facelift is not nearly adequate to describe everything we are doing and how one surgeon's approach may be different to another's, and how what we're doing now may be different to what we did 10 years ago. So when we did a deep plane facelift, 20 plus years ago when I first started doing them, we would enter the deep plane, we'd open the premasseteric space, the lower premasseteric space pretty well, and just a centimeter or two under the orbicularis, maybe we'd release the main body of the zygomatic ligament, but it was not a complete release of the face. I was also routinely releasing the mandibular ligament, and I was doing that from the subcutaneous approach, which I don't think matters anymore, interestingly. So things have evolved. So what has happened in the last 10 years or so, and this is mostly Andrew Chicono, is the extension to what we call a deep plane extended dissection. So one of my great mentors, a guy that really taught me more than anything about the neck, is Tim Martin. Fantastic surgeon. He does a high SMAS facelift a la Bruce Canal. Of course, the floor of that dissection is the same plane. It's just that you take the skin up as a separate layer, then you bring the SMAS up as a high SMAS flap, but it's the same dissection plane, right? I still think what I'm going to show you is a superior operation, but I learned a ton from Tim. Tim would go through that main body, the zygomatic ligament, and then go maybe a centimeter down zygomaticus major and evidence motion at the corner of the mouth, and that was kind of the extent. And so for many years, even my deep plane facelifts, that's what I did. I took the main body of the zygomatic ligament, I'd mobilize maybe a centimeter down zygomaticus major, and that was kind of understood to be what you needed to do. In reality, there are zygomatic ligaments, there are attachments all the way down the body of zygomaticus major, all the way to the modiolus. And if you want the best mid-face repositioning, the best corner of the mouth repositioning, the most passive motion of the face and natural look of the face, you actually have to release the attachments of the layers 1, 2, and 3, or layers 1 and 2 as you get that far forward, all the way off zygomaticus major to the modiolus. Because the entire face is swinging down, you can't release half of it and swing the back half of it up and leave the anterior aspect still attached to the floor. So one of the big changes in the last many years has been extending the dissection all the way down to the modiolus. And it really does create dramatically better repositioning of the face. It's preservation business. So the goal, so far that has been deep plane facelift and what I call modern deep plane extended facelift with full release. Preservation, the idea is to minimize delamination, minimize subcutaneous dissection. And all this stuff came up with discussions I've had with many of my good colleagues. By minimizing the delamination performed, you minimize the consequences of delamination. Hematoma, seroma, telangiectasia, ischemia, those are almost exclusively conditions created by operating layer 2. Can you get a hematoma of the deep neck? Absolutely. Can you get a hematoma of the deep plane? Absolutely. Are you likely to? No, it's almost always layer 2. Seroma is almost always layer 2. Telangiectasia and ischemia caused by starving the skin is exclusively because you operate in layer 2. And subcutaneous fat atrophy, all these things are layer 2 problems. The sins you commit in layer 2 are what really generate these problems. So if you stay out of layer 2, you're safer. Interestingly, what I'm going to show you with this preservation approach dramatically improves the control of the skin of the low neck. This used to be my kryptonite. You know, there are a couple things I just couldn't fix: malar mounds and wrinkling of the low neck. Those are things I just couldn't improve. And again, Tim was one of my heroes, and I learned it from him that you need to dissect the skin all the way down past the lowest wrinkle in the neck. It's exactly the opposite. The more you disconnect the skin from the underlying platysma, the worse control of the skin you have and the less improvement of the skin you have. And I have 3 or 4 doctors in my office every single day watching surgery, and every day they don't believe that by leaving the skin attached to the platysma, you get much better skin improvement. It sounds so wrong. It sounds like you have to take it off and stretch it out, otherwise you won't improve the skin. It's exactly the opposite. And to me, I started calling it preservation facelifting 3 years ago, because as I was doing it, developing it, it paralleled to me preservation rhinoplasty. So if you do preservation rhinoplasty and you leave Pitanguy's ligament intact, you leave the scroll ligaments intact, immediately at the end of surgery, you see beautiful shadows in the lateral nose. You see beautiful shadows in the super tip. You don't go through that period after open structure where there's a kind of formless nose and it takes a year for the skin to contract. You immediately see that. Similarly with preservation rhinoplasty, most of the shape changes you're doing, let's say of the dorsum, are along the nasal facial junction. They're not right under the surface of the skin. So with this, we're making all of our shape changes deep. We're leaving the skin, fat, platysma together. We're undermining only where needed, just like with preservation rhinoplasty, only where needed. And because we're leaving these fibroseptal attachments, which I will show you, that keep the skin attached as much as possible to the smashed platysma unit, immediately at the end of surgery, you see these beautiful shadows and beautiful contours, just like with preservation rhinoplasty. So that's kind of what made me start calling it preservation facelifting a few years ago. So here's the traditional deep plane entry, as Dr. Kamal showed us. In order to do this, I used to undermine everything in yellow. I used to undermine all the way forward to be able to enter that deep plane. I used to undermine 1 or 2 finger breadths over the mandible to release the mandibular ligament. I used to undermine the skin of the vertical neck all the way down past the lowest wrinkle, because that's what I was taught was necessary to improve the skin of the neck. So that was my previous undermining. Now, by retroplacing the deep plane entry, and again, you can retroplace it even further and go, you can cross over Pitanguy's line, but let's say you're going to be very safe and you just displace it back to the blue line. Now we only need to undermine this much skin, right? So we only need to undermine the skin as far as necessary to reach that retroplaced deep plane entry. Submentally, only undermine just enough to be able to enter the subplatysmal plane and do the deep neck work. And again, that'll be a whole different talk at IFATS. But not undermine the vertical neck any more than 1 centimeter beyond the hyoid, and leave all of the skin below that still attached to platysma. Leave all of the skin in the anterior face still attached to the SMAS, and not undermine over the mandible at all. So this is now the full extent of my skin dissection compared to what I used to undermine. So it's probably 40% less than what I used to undermine. Maybe 50% less if you look at the front view than what I used to undermine. So this is part of a chat from a couple of years ago. It's my St. Louis facelift group chat. I have a kind of mentorship group. It started with doctors that had been to visit me, and it's grown to be almost 4,000 doctors around the world now. In this group, one of the docs, a Canadian surgeon, great guy, Mike Roskies, commented that on his first side, the right side, here, hold this 1 second. I'll read the whole thing. I just wanted to share anecdotal experience as of late in the hopes that it helps someone too. I thought I was going crazy, but my left neck results were superior than my right neck, sometimes substantially so. It occurred to me he would delaminate the skin more on one side, on the first side, and by the time he got to the second side, he was getting lazy and tired, and he didn't fully delaminate the skin. And as it turns out, I think this was the difference. Having the skin just inferior to the gonial angle maintain its attachment to the platysma allowed him to create sharper definition on that side. And so Mike Roskies mentioned this in this chat. And so I started trying it and I loved it. And so I call it Roskies patch. Roskies patch, if you look in this diagram, it's the little isthmus where you can see I undermined subcutaneously in the green in the front. I undermined subcutaneously in the green in the back. But just under the gonial angle, there's no subcutaneous undermining. The skin is still attached to platysma. Okay. So what this diagram represents is in the green, I'm subcutaneous. The blue, I've gone under the SMAS. And in the purple, all of that undermining is being performed, but it's being performed under a composite skin SMAS flap. Okay. And importantly, you'll notice that there's that purple under the gonial angle. The skin is not released from the platysma there. That's what I call Roskies patch. And the purple down the front of the neck, the skin is not released from the platysma there. So this is the first woman I did this on. And I like her as an example. I'm sorry I can't get a pointer to work, but I like her as an example because if you look at the dermatohiliosis, the poikilodermia on the bottom, the base of her neck, you can see the redness on the before picture is well below her cricoid cartilage. And the day after surgery, you see that redness has been stretched all the way up above her thyroid cartilage. If you look at the white part of her skin that's not as sun damaged, on the before picture, that white part droops all the way down past the prominence of her thyroid cartilage. And in the after picture, that white part is compressed into a tiny stripe at the level of her hyoid. So again, you can kind of track the sun damage and see how much vertical motion occurs in the skin of the low neck by not undermining and by leaving that patch attack. So that patch, the idea is normally the submental skin, it's being controlled if you undermine broadly. When you shift the skin posteriorly, remove the excess at the occipital hairline, you're creating tension of the segmentum by tightening skin only and insetting it at the occipital hairline. You have maybe 15 centimeters of skin elastic modulus between this control and your inset. When you keep Roskies patch intact, you're controlling the segmental skin from right next door, from the fibroceptal attachments to the platysma immediately next door. So you're cutting the amount of distance in half from where you were controlling the skin from, which makes it a much more powerful control of skin. All right, so this is the first lady. Again, if you just look at the white part of her neck has been compressed up to her hyoid practically. and the red part in front of the cricoid is stretched all the way up over the thyroid cartilage. That was her 1 year result she sent me, right? Almost all my patients travel in, so it's hard for me to get in-person follow-ups, but that was her 1 year. And you can look at the same colors, they're still there in the same shape. So anyway, that was the first one I did. Since then, I've done several hundred. And all of these have the exact same delamination pattern, only delaminated to a centimeter below the thyroid, sorry, a centimeter below the hyoid, left Raski's patch intact, and left the skin of the vertical neck attached to the platysma. Every time I say this, in every presentation, every time I have a doctor in my office, they say, okay, that's great. But what about when the skin is bad? What about people with bad skin? Then you must undermine the skin all the way down the neck, right? Well, this is a patient that actually Steve Cohen was influential enough. He got me to be one of the keynote speakers at MCAS 2 years ago. And MCAS sent their camera crew to my office in October of 23, I want to say, and filmed this surgery. So I'll show you her results in a minute. Even in this, we're going to do the exact same approach. It's not the skin. So this patient, if you just look at this skin, it looks like it is old, thin. You can see the loss of body in the dermis. You can see all the dermal adnexa poking through this thin, wrinkled skin. Well, this is a fake out. This skin is 37 years old, and it's just being compressed forward by my fingertips. All right, so that's my partner, Dr. Kachari. He's 37, but when you compress the skin forward, it looks photo damaged. And it's not photo damaged, it's perfect. You just let go of the pressure, and it's evident that it's not photo damaged. And so I submit to you that this lady, yes, she has photo damage, but the same thing is happening. Her platysma has slid so far forward and down, it's dramatically exaggerating the amount of photo damage that we think she has, right? So this is the lady I did for MCAS 2 years ago. What I undermined was only in blue. No skin delamination except for the blue to reach the new deep plane entry point and to be able to do the deep neck work. That's what the central pocket is. I left Roski's patch intact. In red is what I would have undermined in previous years, and I would have certainly undermined all the way down to her clavicles because that's what I would have thought was important. So in blue is the only undermining that I did. This is her 1 day result. She's got tan lines. She's unfolded so well in her neck. This is her 6-month result. She's had no resurfacing at all. No peel, no laser, nothing to treat the photo damage at all. No fat, nothing. Just unfolded her skin. So she had a brow lift, deep plane facelift, brow lift, preservation, deep plane facelift, and a deep neck lift. It's not a perfect result, but it's half the surgery I used to do, and it's 10 times the result I could have gotten in her neck before I started approaching it this way. No resurfacing, nothing done for her photo damage. This is the lady from the beginning of the presentation. I did the exact same undermining pattern, no difference. So heavy neck, loose neck, I treat them both exactly the same. I do the deep neck sculpture as needed. That's an anatomic decision. And then I do the limited undermining preservation deep plane facelift. This is her 6-month result. And this is her 1 year result. And again, if you look at the change all the way down to her clavicles, it's night and day better than I used to be able to get when I was doing more surgery to these people. So it's less surgery and better results. Lateral mandibular definition, we'll get into this in more detail at it's mostly from deep neck work. The anterior part is deep fat, the mid body is submandibular gland, and then the gonial angle, a little bit of subcutaneous fat, sometimes augmentation. What I don't do ever anymore, I don't do this platysma myotomy ever anymore. The reason for this was something that Andrew came up with, a long horizontal myotomy under the body, the mandible, under the gonial angle and body, the mandible, to try to improve definition of the body, the mandible, and also to try to train in the submandibular gland. This is a mistake. The submental SMAS tension is created from the facelift. It's not created from any posterior motion. The submental SMAS tension is created from the facelift vector. So if you take your own hands and lift up on the sides of your face, you will feel the submentum feels fantastic. It's supported and feels great. Now imagine you do that, and immediately under your fingertips, you come back and cut. You lose all that tension and you lose that support in the submental neck. And so I did this for a couple of years, and it led to a huge run of revisions in my practice where I had to go back in and find that myotomy and repair it and redo their lift. Huge run revisions. So I think it's a mistake. One myotomy I do still do, though, is sometimes a single or sometimes multiple little ones across the lateral aspect of the platysma. Because in people that have really dynamic smiles, when you leave all the platysma attached to the skin and do a really nice preservation lift, it doesn't get better. Sometimes it actually gets worse because of tension on the platysma. So I don't delaminate it. I'm just cutting the platysma, just cutting the back of the platysma right as it's still attached to the skin, to help release that kind of thing. So wrapping up, I used to have this much dead space, the yellow. Now, by the end of the operation, when I've inset the SMAS flaps, the only dead space is what's in green. There is very little cutaneous dead space left at the end of the operation. We're staying out. You know, I used to feel like I was safe when I was in layer 2 because the nerves were not in the field. Now I feel like I'm dangerous when I'm in layer 2 because all the things I cannot control, seroma, ischemia, telangiectasia, they happen as a result of layer 2. So I feel more safe now in layer 4. So now I'm only in my dangerous plane, layer 2, in what's green. So at the end of the operation, there's almost no problematic space left. So I don't feel the need to drain people anymore. When I was doing those big dissections, undermining all the way down the neck, I used suction drains to prevent seroma. Now the dead space is so small that fibrin glue is plenty. So I use fibrin glue, dry up the field. You've probably all seen this before, so I'm not going to belabor too much. And then we spray in fibrin glue, let it seal, and then do our routine closure. You could also use the hemostatic net. If fibrin glue is out of budget or unavailable, the hemostatic net is a viable alternative. So in summary, unwrap the face, change the volumes as needed, again, beyond the scope of this, but it's usually sculpture of the deep neck and addition through fat transfer or implants to the jawline and face. Full release of the SMAS platysma unit in the extended deep plane fashion, but keeping as many of the tissue planes composite as possible in the preservation deep plane fashion, limiting the skin undermining only to the essential. And that combination has made my facelifts dramatically better with less stress and less work. So that's the presentation. Thank you for your kind attention.
Thank you very much. Dr. Kamo, can you assist on the Q&A?
Yes, very
Trying
fantastic,
to stop sharing.
fantastic
I can't
lecture.
find my. I'm trying to stop sharing. There it is. Whew. Okay, there we go. My cursor vanished, so I had a hard time stopping sharing.
Yes, for the audience, if you have any question, you can ask the question to the Q&A or the chat box. Okay. So the first question from our audience is from Dr. Kurdo. So he said he found persistent fullness of the neck after performing a preservation deep neck. And what? Sorry. Yeah,
I see the question.
after, yes. So how you
Honestly,
solve the problem?
it's
Fullness
hard to
after
answer. It's kind of like saying I had a bad result. What did I do wrong? I have to see the patient and or watch the surgery to know 100%. There's too many. It could be fat, it could be gland, it could be improper vectoring of the platysma mass lift, it could be fibrous tissue, it could be there's too many answers to that one because it's basically saying tell me all the right things to do. I don't have a good answer for it, unfortunately.
So do you think can you have to do the some of the open neck in case of the question? Fullness
Well, what
after
I'm saying
doing
is
and the
I
full.
know, but it's kind of I know this is going to sound funny. It's kind of like saying I did my surgery and the patient still looks old. What did I do wrong? It's a very broad question because so many things can contribute to fullness. It could be fat, it could be gland, it could be muscle, it could be the vectoring of the lift was inappropriate because that makes a big difference too. So I don't have a good way to give a targeted answer to that question because the question is really broad. It's basically saying my patient still didn't get a good result even though I did the surgery. The surgery probably could have been done differently, but I can't guess exactly what the problem or problems were from just that.
So the deep neck and the submandibular gland removal is a routine for you. Do you
I
do
open the
routines?
neck. I open the neck in almost 100% of patients. If only to be able to undermine platysmal flaps, even if I'm not taking anything out of the deep neck volume, I will always undermine platysmal flaps, do a hyoid fasciotomy to allow the vertical neck and the horizontal neck to move independently. And again, we'll get into that at IFATS. Measure the excess platysmal length and get rid of the excess platysmal length so that when I do the lifting, everything's invested at the perfect size. I don't always sculpt the deep neck. I sculpt the deep neck in probably 75% of patients in terms of gland and deep fat and digastric. But in almost 100% of patients, I at least open the neck to be able to treat platysmal excess and separate the vertical from horizontal necks through hyoid fasciotomy.
Another
But
question?
deep neck sculpture is probably 75%.
75%. So another question from Asian. Do you have any your technique? You have any difference in for the Asian patient? You have the same result or
Yeah, it
any
works great.
difficult? Yeah, the same.
No issue. Asian patients, I will say, with Asian patients, I do a lot more buccal fat removal. Um, I probably debulk buccal fat in 30-40% of my Caucasian patients. It's probably going to give Steve a heart attack. 30-40% of my Caucasian Asian face patients, I feel like they need their buccal fat treated. And Asian patients, I'd say it's 90% need their buccal fat treated.
This is maybe the same question. May I ask you again to they ask to contour the neck with submental incision. Okay. What structure that you manipulate to keep the best result? He asked for
So
the
that's a
structure.
to contour the neck this submental, that's a whole presentation, and we'll do that at IFAT. So I think today was kind of an introductory lecture. That's an hour-long presentation. How through this incision do you sculpt the neck? The bottom line is it's all of the layers. We start deep actually, and subplatysmal fat, digastric, submandibular gland, hyoid fascia. Do as many changes as you can there. Try to get all of the sculpture done there, and then measuring the platysmal excess, and then a platysmoplasty, and then I do the entire facelift, and then I come back at the very end of the surgery, and if the contour is still not right, then and only then do I start removing subcutaneous fat. I do all the shape changes deep to the platysma. I do the lateral lifting, and only then do I consider removing subcutaneous fat. It's much less than you think, and it's also in a different place because once you've done the lift, the subcutaneous fat layer is in a slightly different AP and superior inferior place. So it's like rhinoplasty. You would never start a rhinoplasty by raising the skin envelope and thinning the fat on the back of the skin before you do the structure. You would always do the structural work first. And at the end of the rhinoplasty, you would consider thinning the skin envelope or placing camouflage crushed cartilage grafts. Same thing with the neck. You do all the deep structure first.
Do you use the fat grafting, like for
I use it
fitting in
all the time.
your case? What is indication? What is your
I use it all the
indication?
time. So I use it all the time in the periorbital region,
Oh,
in the temporal region, in the pre-gel sulcus region, malar zygomatic regions. I use it all the time.
mhm. A lot of questions, a lot of questions. If you have the condition of the secondary surgery with the skin, poor skin texture, like the case you just showed, uh, do you do you still? Oh, I think you show already saying that you didn't dissect undermine the skin. Do you
Well,
need
I
to
think
do undermine the skin surface when the
this
skin
question I
quality
think
is
is more
so poor?
specific.
Mm.
This question I think is more specific. I think they're saying that the person had previous surgery and the skin was draped incorrectly when they put it back down. It looks like it's attached to itself. So I don't know that. I think that question has an answer built into it. It's basically saying if the skin is if the skin is draped in a situation where the skin healed into a roll, do you have to undermine it again? And the answer is, I think the answer is baked into the question. So I think, yeah, in that case, that's not a facelift. That's a reconstructive procedure. That's a different thing.
So, and another question, any tip for doing the short neck, the patient with the short neck? Do you have any tip and trick to do short neck?
Uh, Again, we really didn't go over the neck very much in this presentation because it was more about the preservation facelift. But I will say that hyoid fasciotomy really helps separate the vertical neck from the submental neck. It allows the submental neck to rise really well and not be weighed down by the vertical neck, and that can help make the appearance of the neck longer. The other
For
thing, I'll say again is vectoring. Properly vectoring the lift. If you get the right vector of the facelift, you get better elevation of the segmental neck. So the segmental neck, I think people have it wrong. I think people are focused on the neck lift to improve the segmental neck. The segmental neck, you sculpt it first and you lift it through your facelift. You don't lift the segmental neck by anything you're doing down here. You sculpt it to allow the drape to happen, but you lift it through your facelift. And that's why that horizontal myotomy is a terrible idea. It undoes your facelift power on the neck.
when you do multiple surgery like the brow lift, upper lower blepharoplasty and facelift, what is your order of surgery?
I
You
always do
do
the
the
eyelids first because I mark everything, and the eyelid marking is very precise. And I want to read your paper, Dr. Kamal. So maybe you can share it with me. I'm very serious. I want to read that paper. Um,
okay.
the eyelid marking is critical, so I do the eyelid surgery first, and then I do the brow lift, and then I do the
Mm-hmm.
deep neck surgery, and then do the
Mm-hmm.
facelift, and then any subcutaneous removal if necessary. Um, and then if it's a rhinoplasty, I do the rhinoplasty after that, and then lasers or peels or any injectables happen at the very end of surgery.
Rhinoplasty is the last for the surgery,
I
right?
do
The
rhinoplasty at
last.
the end. Yeah.
Okay.
The very
Uh,
last is always the very last is always resurfacing. Laser or peel would be the very, very last. But if rhinoplasty is a component of the surgery, I do it at the very end, just so they're not drip. I do everything under sedation, and so
oh,
if I do the rhinoplasty early, then there's more dripping into the field and that kind of stuff. So I like to do it at the end because it's kind of dirty, and then I'm not worried about them having little drips of blood into their pharynx.
so another question. 60 years old female have a cleft disease, have treated by orbital decompression and craniotomy. If she want to do the facelift, you can. What is is there any contraindication or for you to do the facelift in this case? Grave disease after orbital decompression?
I don't think. I mean,
No,
she's stable at that point. We're not. I'm not in the orbit. I mean, again, it's a really specific question. I would need to know a lot more about that patient, but on the face of it, I think it's possible. But I'd need to have a more in-depth discussion with her care team, with her primary doctor, with her ophthalmologist. But on the face of it, I think it's possible.
okay. So this is my own question. When you do the preservation, nowadays you do you didn't undermine along the mandible. As you said, you did undermine along the mandible. So how
I
did
do not.
you release the mandibular ligament?
I
How do you
don't.
release? You
I
don't?
do it. I do it maybe 10% of the cases. So I used to do it 100% of the time. Now I don't do it at all. At the end of surgery, when everything else is done, if it looks tight and there's a little streak of tightness, then I'll release it from the submental incision. I used to do it 100% of the time. And one of the benefits of doing it was the submental incision, when it's restrained because the mandibular ligaments are intact, the submental incision doesn't give you the same visibility. If you release the mandibular ligaments, that same length of submental incision is you can move the skin, and that same length of submental incision gives you much better visibility into the neck. So I used to release it routinely for two reasons. I used to think it was important in terms of getting the result. I also used to need better visibility because I was not as good at doing the deep neck work. Now that I'm better at doing the deep neck work, I don't need as good visibility, so doesn't bother me as much that it's tethered. And honestly, the mandibular ligament is where the swinging of the face stops. So there's not a lot of benefit to releasing it. That's where the entire face piles up and stops there. To swing the face back, you really don't need to release it. So I do it maybe 10% of the time now. If after I've moved the face back into place, I see tension, then I'll release it. But that's 10%.
Okay, thank you. Any question? I don't know. Can we ask the comment or any from Steve? Yeah.
Sure. No, I want to say that, I think Mike has become one of the preeminent facial plastic surgeons in the world. And what you're seeing is tremendous. Can you hear me?
We hear you, Steve.
Okay. Anyway, I was saying that I think Dr. Nayak has become one of the premier surgeons in the world. And I think these concepts of preservation makes sense tremendously because, as Mike pointed out, the skin is passive. It's attached to the deep layer. It has, in and of itself, it's sun damaged. It could be injured, but it's not lax. The fibromuscular layer is lax. The skin, you know how adherent it is to try to peel off with scissors. It's attached firmly. And I think the brilliance of this approach. Also, I think the endoscopic approaches where there's very little skin to remove kind of respect a new way of thinking, which is really to look at the basics of what's happening anatomically. And that's what Mike has done. And the work is beautiful. And you're not going to find better anywhere in the world. And the thinking, I think, is excellent. So I would say that what you're seeing is just the icing on the cake, or maybe the tip of the iceberg. And I would love for all of you to come in January to see Mike do his work in person and the cadaver dissections, because you will learn really what is, the new direction of facelift surgery. And Mike and others that are starting to pursue this, I think this is what all of us should be thinking about. We need to move away from the simpler operations of delamination and tightening the deep layer, because that has no effect on anything really. You create a little tightening, but you've ruined a junction that is not supposed to be separated. So I think that's the direction. Just a comment.
Well,
Thank
thanks,
you.
Steve. And I agree. I think these wide skin undermining operations are honestly, I don't want to say mutilating because that sounds like you're intentionally doing something bad, but they are unintentionally harmful. You know, the more you undermine skin, you are damaging something that can't be undone. You know, and so I think it's in the patient's best interest that we stay out of layer 2, if at all possible. You know, and limit it to the very least possible to get the result. So I didn't put a lot of result there. One of my pet peeves on presentations is when people don't tell you anything, they don't teach you anything, they just show 100 before and after pictures. So I tried to do the opposite. I tried to give you my thought process, a couple representative results. If you want to see results, that's what Instagram's for. Go over with Instagram and see a ton of results. I tried to mostly focus on the thought process, the why, the reasoning, the evolution, and spend more time on the what's important to doctors, not lots of flashy pictures. But if you want to see pictures, you can see 1,000 of them on Instagram. But I will say, patients just look healthier. The skin looks healthier. The tissues look healthier. They don't look operated when you stay at a layer 2. Even if SMAS plication lift generated the same exact shape as a deep plane lift, which I do not believe it does, it will always suffer from the fact the skin was undermined and put back down. And so there's a secondary benefit.
Yeah, no question. No, beautiful work, Michael, and we really appreciate what you've done and your contributions, and you know the cadaver courses. I mean, I really think that you're leading the way into a new horizon, and facelift results have never been better, never been better, and you exemplify the highest ideals of achieving that. So congratulations. Thank you very much for a fantastic talk, Mike. Really appreciate it.
Pleasure. And you know, I just say it again. I mentioned several surgeons that I was talking about. I got this from this guy, and this from this guy, and this from this guy during the presentation. And I think the thing that has made facelifting so much better so fast in the last 5-10 years is just collegiality and sharing everything. And you know, I mentioned all these guys in my presentation: Tim and Dom and Ben and you and Jerry and Ozan. You know, Andre. You know, if we weren't interacting routinely, the entire field would be behind for it. And it's the interactions that we have routinely and freely sharing information back and forth. That's what's really been, I think, the accelerant, the catalyst for how great facelift's got in the last several years. So anyway,
Yeah.
Thank you very much for having me.
Okay. I think no question now. So I return it to Eddie. You have any announcement?
Thank you, Dr. Kamo. Thank you, Dr. Mike, Dr. Cohen, and of course to all the participants for this webinar. It's early morning in America. It's almost midnight in Australia, and it's late evening in Asia. So with that, we will conclude today webinar. And as you can see from the page, all participants that we are happy that Dr. Mike Cohen and of course Dr. Bravo and the rest of the faculty will be coming to Bangkok January next year. Meet them in person. We have 2 days lectures and pre-recorded live surgery. And of course, on the 3rd day, we have a hands-on cadaver workshop. And most importantly is the demonstration by the 3 gentlemen, Dr. Mike, Dr. Cohen, and Dr. Bravo on this deep plane face and neck lift. So these are the programs. And with that, I will conclude today the webinar. As you can see, you also can scan the QR code if you are interested to join this program in January. Okay, thank you very much, guys. Good night.
Bye. Thank you.
Yep. Yeah. So thanks, Dr. Mike. Thanks, Dr. Kamo and Dr. Stephen.
All right. Bye-bye, guys.
Yes,
Bye.
yes, yes.